GI cancer. I invite our chairpersons, Dr. Supraprata Das, Senior Surgical Oncologist from Udaipur, and Dr. Naveen Goyal, Senior General Surgeon, to come to the first row. And I request now our chairpersons to introduce our first speaker.
We are pleased to welcome Dr. Prashanth Bagali, from who is a clinical genomics specialist from Strand Life Sciences, Bangalore. He'll be speaking on the prevalence of BRAF, PIK3CA, and RAS mutations in Indian patients with colorectal cancers.
Good afternoon, everyone. This is the penultimate session of this 2 days conference, so thank you very much for the opportunity. But rather than having any kind of the serious in-depth discussion, so I will just touch upon the superficially the different aspects of this colorectal cancer and the study which we conducted from Strand Life Sciences along with the Sir Gangaram Hospital and all. So I will share about those details and also, but willing to have a conversation either after this session or please write to me if any of those. So I'm placed in Bangalore, and Strand Life Sciences earlier was actively participating with many of these clinicians. So yesterday also I could able to meet a couple of them, but now it's with the refocus on the different aspects of oncology. So we are into the different areas of oncology here in India. So colorectal cancer is majority of the cases, because again I will not go to the introduction because of this time constraint and all. But what exactly I would like to share is although it's not so major one, because since morning I've been listening to the HRD and our focus also has been on the breast cancer, lung cancer has been on this for the past couple of months, which I've been with this company. So, but the annual incidence rate has been increasing. So that's which little bit alarming, because in the Singapore and South Korea, which I was with the other hospitals and all, we have been seeing couple of cases and all. But in India now, interestingly, for the past few months, I've been seeing the cases where the complexity of the genomic profiling is the need of this better clinical outcome and all. So this is mainly because of the two important factors, both the genetic ones and the environmental factors. Because environmental factors, I understand a lot of changes have been there with the work from home or any kind of the eating habit changes and the kind of sedentary or rather a less physical activity and all. But with regard to the hereditary ones, it has been there, about 4 to 5% has been there in India. I have seen some of the ICMR reports also. They are mainly because of the other syndromes which are all associated with this colorectal cancer and all. So in that perspective, I strongly recommend the comprehensive genomic profiling, because that play a very important role in understanding and to get a better clinical outcome for the oncologist to start the treatment and all. So although in terms of the genes, we are not having so much of the prevalence, because when I was reading through the consensus document from the ICMR published on this colorectal cancer, and also some of the published results coming from the different hospitals and all, then what kind of genes and the frequency, there has been always a confusion. So but that's also made me to strongly recommend for a comprehensive genomic profiling rather than coming out with a reflect test or a concurrent test using some of the IHC and FISH and all. So this is mainly because it has been in the reports in India now that there are multiple pathways which are all involved in this. So later on we will see that what are those pathways and how the study will able to share those details. And yeah, this is again, all of you are aware about this. So hereditary colorectal cancer, and what I would like to handle is these genes are of the high penetrant genes and all. So that doesn't mean that it is a single gene genomic kind of inheritance and all. So they are of a high penetrance genes, and those are really required for the better prognosis and treatment effect. So this is the one which I will take for next whatever the 9 minutes to share with you. So here the 6 genes have been studied in this particular report, which we shared with the the hospital recruitment and with the 3 hospitals. And also again, this has a very multiple of the different pathways which are all involved in this. And of course the NGS is used because that was the preferred one, and this is when it was studied in 2017, and a follow-up happened in 2020. So this was the first report to indicate the frequency of these genes in India, studied together on the different patients and all. So here, if you see, the NRAS has a MAPK and ERK pathway, because that's a very big important druggable pathway for us. And PIK3CA, again PI3K, and AKT pathway, again this has been very well established in the other major cancers, and TP53 pathway, and APC. So APC has been now having a higher frequency in different cancers also. So here the mutation in the frequency of these genes in India has been first time studied, I should say. Although it was 2017, so I did not find any other report of involving all this complexity of the genome. So that way I cannot really promise what exactly is the frequency, but for the past 2 years of data, when I was going through, there has been the incidences that whenever there is a comprehensive actionable panels have been done, so there has been a great impact of this higher frequency and all. So it was in Delhi, and the FFP tissue was used, and the clinical characteristics were correlated with the genetic profile and all. So whenever the FFP tissues are there in my CMEs and all, even in the lung cancer conference in Mumbai and the APSICOM in Hyderabad and all. So I've been speaking about this FFP tissues because and its impact on this our genomic profiling and all. So from the NGS perspective and all, but these are the important ones. You need to know, because earlier it was a responsibility of the histopathologist and a pathologist to provide the blocks and all, but now I think any delays happens to the treatment or a treatment initiations will also have a great impact on the patients. So that way it is equally important from the surgeons and also to the physicians also to make sure that they are aware about this QC parameters and all. So this gives a better estimate about the outcome of the test report. So although because of the time constraint, I will not be explaining about the test and how exactly the clinicians need to read about the test report and what are those important things, the take home messages and all. So here again, because of the complexity of the gene and also the number of mutations involved in this number of genes, what we have 6 genes, so more than 100 mutations are involved, and some of them are very high penetrance. So that's why I just cut short with the timings of this session and all. So I am not sharing those tables and all. But what I am important things I am sharing here is of course here KRAS has 43 mutations and BRAF again has 8 mutations and all. So this is not only the indications of this, but other GI cancers also. So GIJ1 also, esophageal junction also, I have seen couple of them having this kind of the positivity and the pathogenic and likely pathogenic mutations and all. And the NRAS and PIK3C and TP53 48 mutation. So you will also appreciate that the comprehensive panel is only required to cover all these mutations in this scenario. So who needs to be tested? So this is very important because I've been talking to the many physicians and also sometimes they always go a traditional way, what has been like how morning we were seeing a couple of them and also. the personal or the family history of the CRC, because sometimes the family history is absent, because for the yesterday also I've been seeing some of the case studies and all where the patient, family history was not there and all. So that is also, I will always take that when the family history is not there, need to be taken, like we need to establish the family history, at least if they can able to afford. But there has been a balance, has been for me always the affordability and how much they can, you want to have a patient history also. So of the GI cancers, because sometimes these of the symptoms will always overlap, so all of you will also understand that. And also the family history of the uterine cancer before the age of 45, and a history of GI. So I do understand some of these there, but what exactly is important is the family history, how you will establish based on this genetic profile and all, because these need to be, although there has been some initiatives from the digital health and also, because I work with them also collaboratively, and also to establish a genetic profiling or a risk factor for the Indian population and all. So that makes it very important for us to know that there has been a risk factor and predisposition factors occur in the population and all. So this is very important one, because although 6 have been studied, but our team also could able to analyze, is there any coexistence of 2 genes, coexistence of 4 genes, or coexistence of 3 genes and all. Because what happens is there are some concepts anyway. So this data is, I'm not relating it to the clinical one, although CDX companion diagnostics, I love to do that, but somehow I could not able to get this message through and all. But what is important is this coexistence of the 2 genes, 3 genes and more mutations and all. So the concept need to be clear with all of you, is what I could able to request is, say polygenic, because most of the oncologists, although in fact the BRCA1, BRCA2, I've been talking to a couple of them in regard to the loss of heterozygosity, telomic allelic imbalance, and the other phenomena which are all involved in the homologous recombination repair pathway. So similarly here, they are all polygenic characters. So polygenic means there will be a cumulative effect and inheritance, and a pleiotropic effects where the multiple effect of the same gene. So that we are already established, like GI cancers, not only the colon cancers or a rectal one, there have been other cancers associated with that, and the epistatic effect. So these genes work in conjunction. That means there is an interaction about these genes, and that is where my summary will able to say. So no patient had all the 6 genes. So that's why whenever there has been a debate in the some of the some of the conferences where I go, like Association Medical Oncologist in Bangalore, and also so doctor, like 15 genes, another company comes with 20 genes and all, which is better and all. So I always say it's not the number of genes which you are including, you need to have those, what are the driver mutations present in, then what are those high penetrant genes which are included, and what exactly you are going to have an interpretation if it comes positive. So that makes very important in this scenario. So none of them patients had 5 or 6 genes together, but 4 genes has been very common. So at least in the 2 patients there has been the 4 genes, and also 3 genes were observed in some of them and all. So this kind of the concurrently occurring these genes will have a synergetic and a cumulative effect, which will be a really has a higher carcinogenesis and a tumorigenesis for the patients and all. So in conclusion, many studies have reported and confirmed that the CRC can be initiated through the different signaling pathways. So now we have a proof for this, and also 6 genes were although not there, but suggesting that there has been a possibility that as and when we increase the population, because 112 patient population, although there were some QC failures and all, is not a is a true reflection of the Indian population and all. However, a mutual exclusion was also noted. So that's very important, because of course from the area of drug discovery and all. So this is where I say that such a study will able to give a better clinical utility and of course we all care for the patient, so it is covers most of them except of course the monitoring. But however, the liquid biopsy which we are using also nowadays will help in the minimal residual disease monitoring also. So I think that's where I wanted to share with all of you, and thank you very much for your attention. So happily, probably next year I will be able to join and share my knowledge. Thank you very much. So we do the genetic counseling also mandatory, because I make sure that the patients and the relatives will able to get the proper advice and about the risk, underlying risk, and also it becomes easier for us also, and also to have a discussion with the doctors and all. Yeah, thank you very much. Is there any questions, or next person is, yeah.
Many thanks to Dr. Prashanth. It was a wonderful presentation.
Thank you.
It was a very comprehensive talk, which goes in a lot of details. But the take-home message is that though the incidence of these mutations are there, they usually do not coexist with other mutations, and that might have some impact on clinical scenarios in the future. Thank you so much.
Yeah, thank you.
Next, I would like to welcome Dr. Chaturbhuj Agrawal, who's a medical oncologist from New Delhi. He will present his study on Gemcitabine plus Nab-Paclitaxel-Based chemotherapy as first-line treatment in metastatic pancreatic cancers. Thank you.
Thank you, sir. Thank you, sir. Also, to just let our participants know that lunch has been served. So we'll just move on to our next talk.
Good afternoon. It has been an excellent academic pitch since past 2 days, and I will quickly try to finish it in my stipulated time so that I will not keep you people away from lunch. So my job here is to present a study of Gemcitabine plus Nab-Paclitaxel-Based chemotherapy as first-line treatment in metastatic pancreatic carcinoma. And as we all know that pancreatic cancer is a silent killer because it does not cause any symptoms in the early stage. It is the 11th most commonly diagnosed cancer in man, 9th most common cancer in women globally, and the 5-year survival rate unfortunately is only 8%. It is up to 30% in early stage resectable, but it is less than 3% in stage 4. So unfortunately the overall survival rate is only 8%. 52% of patients they are diagnosed in stage 4, and the 5-year survival rate of this dismal subset of patients is only 3%. There are certain risk factors for pancreatic cancer. We quickly go through those because before covering this, it won't be prudent to directly jump onto the treatment. So if there is family history, we know a diet which is high in bread and processed meat. Obese people, they have almost 20% increased risk. African Americans, they have very high risk. Smoking, it causes almost 20 to 30% of all exocrine pancreatic cancer cases. Males, particularly the age more than 75 years, there is very high chance, and more than half of the cases they are diagnosed at age more than 75 years of age. Long-standing diabetes is another risk factor, and chronic pancreatitis again increases the risk of pancreatic cancer, as do certain hereditary syndromes and family history. We have already seen the prognosis, and if we see percentage of cases diagnosed by stage, so almost 50% of the patients they are diagnosed at stage which is metastatic, and unfortunately the survival for this subset is only 3%. And 5-year survival rate is less than 3% for stage 4. For localized curable also, it is unfortunately the survival rates are not great, and it's only in the tune of 30%. So the treatment paradigm is old slide. We all know nothing has changed in pancreatic cancer much. So if it's localized, we have to see whether it's resectable, borderline resectable, or unresectable, and if it is metastatic, which forms the bulk of the patient, we see whether it is oligometastatic or it's a disseminated metastatic disease. So we are going to discuss this subset of patients where it's metastatic and we are treating with palliative intent. So palliative systemic chemotherapy is the treatment of choice for most of these patients. The primary goal of treatment for metastatic pancreatic cancer is palliation, and the survival benefit is usually limited to adequate performance status. The patients who has the ECOG PS 0 or 1, the patients who has patent biliary stent or biliary tree, because most of these patients they usually present with obstructive jaundice and they require biliary stenting, and patients who have got adequate nutritional status. Systemic therapy is therefore only recommended only for metastatic CA pancreas patients who are in good performance status, and overall median survival from diagnosis is around less than 1 year. So if you see the NCCN guidelines, metastatic disease, first thing, because as I said, most of the patients they present with obstructive jaundice, and if jaundice is present, then placement of self-expanding metallic stent is has to be done first. Genetic testing for inherited mutations we have to do, and molecular profiling obviously if it has not been done we have to do. And immediately we place our patients as per their performance status. If the performance status is good, then we try to give these patients palliative chemotherapy until there is progression or toxicity, or up to the maximum number of 4 to 6 cycles of chemotherapy as per oncologic treatment. But if the performance status is poor, then immediately we go for palliative or bed supportive care, or consider solution of single agent gemcitabine-based chemotherapy or targeted therapy if we can find some strongly targeted mutation probably. Palliative work is written, but it has got very limited role in metastatic CA pancreas, particularly preferred for pain relief. So if we see 2017, 5 years back, so what was the NCCN, what were the options in NCCN guidelines? So NCCN guidelines, again, it has mentioned FOLFIRINOX, gemcitabine, Nab-Paclitaxel, gem-agglutinin, single agent gemcitabine, and for patients with poor performance status, again, single agent gemcitabine either weekly for 3 weeks followed by 1 week care, or fixed dose gemcitabine. And particularly for hereditary BRAF positive, gemcitabine cisplatin was a possible option. So this was way back in 2017, March 2017. Now if we come to 2022 again, if you see, only they have made the categories, but most of the things are same. Again, FOLFIRINOX, gem-Nab-Paclitaxel, gem-cisplatin for BRCA positive cases, gem-agglutinin again category 1, gemcitabine single agent category 1, and for poor PS patient again gemcitabine. So what is new? What is the difference these 5 years has made in pancreatic cancer? Like we see in breast cancer, in lung cancer, almost everything has changed. But in pancreatic cancer, it's very dismal. So what two new things are? Only pembrolizumab has come up for MSI high tumors, and pembrolizumab and NTRK inhibitors, they have come up for poor PS patients. So not much of advancement in systemic therapy as far as pancreatic cancer is concerned between in the last 5 years. So just to re-emphasize that how important is performance status of the patient. So if patient has ECOG performance status 0 or 1, FOLFIRINOX and gemcitabine Nab-Paclitaxel, they are both are category 1. But if performance status goes down, gem-Nab-Paclitaxel is definitely preferred over FOLFIRINOX, because we also said the toxicity of FOLFIRINOX is very high. And if the patient is very elderly, as I said, pancreatic cancer mainly occurs at more than 75 years of age, or if performance status is very poor, then preferably single agent gemcitabine or best supportive care. If the patient progresses on first line, then these are the possible options. If the patient has already received FOLFIRINOX, then gemcitabine. If the patient has received gemcitabine and Abraxane, then probably we tend to give either FOLFOX-based auxiliary treatment-based regimen, or if the patient has PS of more than 3 and he has received already 1 line of chemotherapy, all of us would agree that we prefer best supportive care. So, means evolution of chemotherapy in pancreatic cancer, if we see, there is not much discovery, or there is no substantial gain in last 2 decades, except when in 1997 gemcitabine became the standard of care, and it was subsequently reported by a backbone of chemotherapy. So initially it all started with trying 5-FU single agent, which had only 28% response rate back to on clinical basis. So since 1997 gemcitabine came, and from 1997 till last decade, there are a lot of chemotherapy agents which have been tried to combine with gemcitabine, but there is very negligible benefit. And with the exception of ROT, even targeted therapies like cetuximab, bevacizumab, exitumab, trastuzumab, nothing has shown any benefit. So this is the gemcitabine registration study. If we have a first line stage for pancreatic cancer, we give either gemcitabine or 5-fluorouracil. But if we compare them head to head, so it was found that gemcitabine was found much beneficial as far as the analgesic consumption rate, pain intensity, or improvement in cardiovascular performance scale is concerned. So you can see the benefit that gemcitabine, it has clinical benefit response of 24% as compared to traditional old 5-FP, which was there before 1990, it was only 5%. And that too the clinical benefit, not on imaging. So gemcitabine has definitely found much more beneficial than 5-FP, and this study, gemcitabine registration study, led to the establishment of gemcitabine as the most important chemotherapy metastatic pancreatic cancer. Fixed dose gemcitabine has been tried. We will not go into detail, but in fixed dose gemcitabine, the concept was to increase the intracellular concentration of phosphorylated form of gemcitabine. And if we compare fixed dose gemcitabine versus standard gemcitabine, there was again a PFS improvement of approximately 1.5 months. When NCCN panel they recommended that fixed dose gemcitabine is a reasonable alternative to standard infusion of gemcitabine, particularly for PS patients. Then people started trying gemcitabine combination, and then came the evolution of FOLFIRINOX, gemcitabine, Nab-Paclitaxel, gemcitabine, Agrawal. So all these chemotherapies they evolved in previous 2 decades. So this was the first trial. So everyone was trying to repeat gemcitabine and trying to prove superiority of the regimen of gemcitabine, which was a standard of care before 20 years ago. So this was FOLFIRINOX versus gemcitabine. We all know this study. So FOLFIRINOX is a very toxic chemotherapy which was not tolerated by many of the patients. So patients who were less than 76 years of age and ECOG age 0 to 1, they were either randomized to FOLFIRINOX versus gemcitabine. So this is Project 4, which trial which led to approval of FOLFIRINOX in as first line in metastatic CA-pancreas. So if we see the median OS with FOLFIRINOX, there was a 5 months improvement in OS and almost 3 months improvement in PFS, with a very significant improvement in hazard ratio. If you see hazard ratio of 0.47, we don't see this hazard ratio so often in pancreatic cancer. We have seen this hazard ratio multiple times in breast and lung cancer, but not in pancreatic cancer. Next came gemcitabine plus aluminum paclitaxel, which is the topic of discussion. So this was a phase 3 MPAC trial which combined gemcitabine plus paclitaxel, and the patient with no previous treatment in the first line with carcinoma performance status of more than 70 and bilirubin, normal bilirubin. So they were randomized to either Nab-Paclitaxel gemcitabine or gemcitabine single agent. So if you again see the median OS, there is 2 months, approximately 2 months benefit in OS, and there is almost 2 months benefit in median PFS. Hazard ratio was not that great which we observed in Project 4, but yes, that's better. Preferring gemcitabine Nab-Paclitaxel combination over gemcitabine. But what is the main difference between how do we choose FOLFIRINOX or gemcitabine? So the main thing, what we are main concern with FOLFIRINOX is toxicity. And if we see grade 3 and 4 hematological toxicities, they are much more with FOLFIRINOX as compared to gemcitabine, almost doubling of hematological toxicities, almost 3 times more febrile neutropenia, and almost 3 times more thrombocytopenia. Apart from hematological toxicities, even non-hematological toxicities, they were much more in FOLFIRINOX as compared to gemcitabine. Now, if we compare the MPAC study as compared to gemcitabine, Nab-Paclitaxel adverse events leading to death almost same. Neutropenia rates not much great. Leukopenia, yes, there is doubling of leukopenia rate, but there was very less febrile neutropenia. In fact, febrile neutropenia is forced in only 3 patients as compared to 1 patient in the gemcitabine arm. Out of 421, only 3 patients. So non-hematological toxicities are also not great. There was some concern of peripheral neuropathy due to Nab-Paclitaxel, which was seen in most of the patients who received Nab-Paclitaxel, but it's most of the time grade 1 or grade 2 and very much controllable. So the MPAC trial, if you see the median overall survival, it was much better. Median PFS was much better, and there is separation of curve right from the beginning. So right from the treatment start, the patient they experience there is almost improvement in symptoms. There is weight gain, and if we can see the separation of curve, it persists till the end. And the adverse event profile we have already discussed. So adverse events are not much great in gemcitabine plus nab-paclitaxel as compared to gemcitabine alone. Neutropenia and leukopenia rates were there, and particularly the peripheral neuropathy of the. So apart from this, there is no significant concern with gemcitabine and nab-paclitaxel. So based upon this, we from Rajiv Gandhi Institute we published our own data. So it was basically a single arm study of gemcitabine plus nab-paclitaxel as first line therapy in metastatic LPS, and what we found is similar to previous study. In fact, our response rates were more. So disease control rate was 76%. So what we found with previous study, the response rate of 50%, stable disease rate of approximately 20%, and almost 26% death progress. So similarly, almost 75% is the disease control rate which we found. There was no complete remission, but partial responses were found in almost half of the patients, 56%. And PFS was approximately 6 months, which is well matching with the previous study by Quinton et al., Hoff et al., and Derrick et al. So these were our results. Almost half of the patients had partial response. There were no complete response. 26% patients progressed, and 20 patients had stable disease. And the disease control rate was 76%, and the median PFS was 5.75 months. So most common toxicities, as I told before, that anemia, neutropenia, and nausea and fatigue. So these are the common, and some incidence of peripheral neuropathy due to nab-paclitaxel. So this was what we found, and this is frontline regimen. So these are the two most common used regimen: folfirinox versus gemcitabine. We should not be doing cross-trial comparison, but this is Prodigy 4 versus AMPAC if we see. So if we see the median overall response rate, it was much higher in the folfirinox arm. Disease control rate was much higher in the folfirinox arm, and median PFS again it was much higher in the folfirinox arm as compared to gemcitabine. And in fact, median OS was also highest in the folfirinox arm. But to remind, folfirinox is only for patients who are PS1 or PS0 and who are very much fit for chemotherapy, while gemcitabine nab-paclitaxel is a reasonable alternative for ECOG PS1 and even PS2 patients. After that, several new agents they came into action, discussion of BRAF mutation and discussion of PD-1 and PD-1 antagonists and agonists are beyond the scope of this presentation. But while frontline naltrexone localized from advanced or metastatic pancreas has been tried, and this was the basis for basically current phase 3 Napoli-3 trial, which has been registered. They also tried nab-paclitaxel, gemcitabine, cisplatin, a triple drug combination with metastatic LPS. So the median OS was in fact way more than what was observed in folfirinox arm. So it was 16.4 months with median PFS of 10.1 months. But most common problem was what patients had is grade 3 or more adverse events with thrombocytopenia rate of 68%. So this is something which was of very much concern, and I think it is very difficult for patients to tolerate a triple combination of this sort. So this is how we go in metastatic pancreas. If the patient is less than 75 years, we see ECOG 0, ECOG PSCP 0 or 1. Folfirinox is preferred as compared to gemcitabine nab-paclitaxel, considering the longest OS and PFS. If it's PS2, then definitely I think gemcitabine nab-paclitaxel takes the upper arm over single agent gemcitabine, and if it's PS more than 2, then either best supportive care or single agent gemcitabine. And if it's more than 75 years, then I think folfirinox is practically out of option. We prefer gemcitabine nab-paclitaxel followed by gemcitabine. And if it's PS more than 2, then only best supportive care. So how to select the first line chemotherapy regimen? I think we have seen a lot of data, but we have to check performance status, age, comorbid conditions, risk of stent complications. So the patient preference sometimes it matters a lot, because when you give folfirinox during the 48-hour infusion, but gemcitabine nab-paclitaxel is more convenient chemotherapy option for patients who want to continue their work. And what about predictive biomarkers? I already mentioned there are a lot of predictive biomarkers, but it's beyond the scope of discussion for today. So in 2014, UK started this pancreatic cancer survival campaign, and it's the most treated cancer. Most patients were diagnosed with diabetes 4 to 6 months of diagnosis. Only 7% of patients or maybe less than that survive for 5 years after the diagnosis. and it causes the worst pain, and it is the most deadly cancer out of 22 most common cancer detected across the world. So this is the storyline from one patient who just shared his feeling, her feeling that she wished that she had a breast cancer or some other malignancy instead of pancreatic cancer. So thank you very much. Thank you once again to our organizers. And if there are any questions, I will be happy to take. Thank you.